Well, good afternoon, everyone. Thank you for joining our webinar. Thank you for your time this evening. I know everyone has very busy schedules, so we appreciate you taking time to tune in. I'm Leah Fine. I am the Senior Director for the Excellence in Screening and Care team here at the Go-To Foundation for Lung Cancer. We're excited to kick off our Incidental Pulmonary Nodule program this evening with two great speakers. I'll get to introductions in just a moment. But I did want to provide an overview of how Go-To is thinking about incidental nodule programs and why it's such an important aspect of early detection of lung cancer. And I just want to check in with my colleagues to make sure that they can hear me clearly so far. Everyone able to hear me?
All clear.
Great. Okay, I am going to just give a brief introduction about how we are thinking about incidental pulmonary nodules here at the Go-To Foundation. The reason that incidental pulmonary nodule management is so important to us is because it really represents an opportunity to identify patients with lung cancer much earlier than perhaps they otherwise would be detected. When we think about incidental pulmonary nodules, this refers to all of those, if you will, accidental finds of a suspicious nodule that occur on, within CT scans or other imaging that are performed for anything other than a low-dose CT lung cancer screening. So these are images that take place all over the healthcare system, within emergency departments, within cardiac departments, a whole host of reasons why people are getting scanned. And so the number of actual scans is pretty vast, and the patient numbers that have something found is also quite large. And these are patients that are already captured within the health system. So these incidental pulmonary nodule programs are a key, if you will, parallel track to early detection alongside low-dose CT screening programs. And again, many of these patients are already captured within the healthcare system by virtue of already being scanned. As we said earlier, many of these images do show a suspicious nodule, and in many cases, they're not appropriately followed up. And oftentimes that might be because the workflows don't exist, or technology has yet to be adopted, or people just aren't aware. So our goal at the Go-To Foundation for Lung Cancer is to really build out our early detection program to include both the incidental pulmonary nodule programs and low-dose CT screening, and help to educate and expand the knowledge around the value of incidental pulmonary management. So the ideal scenario is we want to be able to have every single, incidental flagged and followed up. And we want to be able to determine with confidence which ones are cancerous and which require immediate attention and intervention. And those that are benign should be safely monitored without unnecessary procedures and costs. So we want to make sure that we are able to very quickly and efficiently and confidently divide up those incidental pulmonary nodules into the two groups of benign and cancerous, and take the appropriate steps to treat those patients. What we know today from within our COE program, where we have many pioneers who are already putting incidental pulmonary nodule programs in place, is that a significant number of lung cancers are actually found through this source of patients. So it becomes very important to not only understand how that's being done, but how that's being done well, so we can actually capture even more patients. Oops. So why should we care about IPNs, and why is it important to care now about IPN or incidental pulmonary nodule programs? So again, there is a significant opportunity to identify these early stage patients and to offer them life-saving treatment options. Many of these patients, our COEs are reporting, a significant percentage of those patients who are found through incidental findings actually would not have qualified for low-dose CT screening programs. So in essence, we're sort of expanding our net to be able to capture more patients. Even if we were able to get 100% of patients participating in low-dose CT screening, incidentals actually captures those who fall outside of that bucket. So it is very important to expand these incidental programs to capture those patients. You might say that IPM programs are somewhat a little bit more COVID-proof than traditional screenings. We have seen through all of our COE programs that screening rates are way down for obvious reasons in the COVID environment. But if patients are still being captured within the system, in a sense, the activation energy to find those patients is much lower. There are much fewer friction points than trying to convince people who may be at risk for a number of other disease indications to come in and get screened. So it creates a source of patients that we can really tap into for early detection that are already captured within the system. And what we're also seeing is the emergence of workflow technology solutions, software, artificial intelligence that are really being applied to the workflows and the patient management of incidental pulmonary nodules. And so there's a lot of really great tools that are being implemented within our COE centers that's basically allowing this to happen much more efficiently, cost effectively, and the ability to identify those patients and get them flagged and get them in. And I do want to give a plug for GO2 Foundation, because we've identified this as a key opportunity and we're building out the resources to help you do this. So we want to encourage you to reach out to us and within our COE community to reach out to colleagues, because we are demonstrating that these workflows and that the implementation of these new technologies and innovations are enabling us to find more patients early. My colleague Kim is putting together the IPN task force and the consortium to help lead these best practices and help to expand the education and knowledge across the COE program. And she's also working very hard to build on the business model that was rolled out. And certainly I want to give a shout out to our speakers today, because a lot of that work in the business model really stemmed from the initial work that Dr. BHADRA and his team have done to help forecast program growth and revenues and to make informed investment decisions, both about building out incidental programs as well as low-dose CT screening programs. So please reach out, contact Kim to get your program started or to ask questions. So this is really the first of many opportunities for you to connect with GO2 Foundation, and we are certainly here to help. I do want to introduce Dr. Skibo and Dr. BHADRA and welcome them to our event this evening. So let me just pull up their bios. Just give me a moment here. Okay. So I want to welcome you all to the changing landscape of pulmonary nodule management. Incidental pulmonary nodules should be a part of your early detection strategy. And we want to kick off with Dr. Scott Skibo, who is the Director of Interventional Thoracic Oncology for Duke LifePoint and the Chair of the Nodule Governance Council at LifePoint Health. We will also be hearing from Dr. BHADRA, who will present a case study on the business of thoracic oncology. Dr. Krish BHADRA is the interventional pulmonologist at CHI Memorial's is it Stantler Lung Cancer Center or Lung Center, and the GO2 Foundation, and a member of the GO2 Foundation Scientific Leadership Board member. So with that, I will hand it off to Dr. Scott Skibo, and he can share his perspective and experience with incidental pulmonary nodules. Thank you.
Thank you, Leah. Let me share my screen here.
And as Scott is sharing his screen, I do want to make people aware that we do have a Q&A feature at the bottom of the Zoom webinar.
All right. Well, thanks, Leah, and thank you, everyone, for joining us tonight. It's certainly a privilege to be speaking on this. So Krish and I have the opportunity to talk on the changing landscape of pulmonary nodule management. Certainly, especially in the age of COVID, a lot is certainly changing, and I think there is an opportunity for growth and improvement. It's almost goes back a decade, this data, right? And so it's almost not worth mentioning because everyone kind of knows that, hey, there's a 20% mortality improvement in the NLST trial. you need to screen 320 people to save one life. The Nelson data came out kind of corroborating what we found in the NLST, that there's a benefit to this. So, it's guideline endorsed and United States Preventative Services Task Force recommended thing to do. And it really no talk on pulmonary nodules, as Leah already alluded to, is complete without talking about lung cancer screening, but also like the bigger thing in the room, the bigger elephant in the room is incidental nodule management, which you'll see is really accounts for about 95% of the pulmonary nodules that we see on a year-by-year basis. But lung cancer screening, despite data that supports it for a decade almost, right, is really legs, right? And we really can improve upon this. If you look at, this is the 2018 data. So this was published December 2nd, 2019. So it's the most recent data that I was able to find anyway. Looking at rates across the United States. So, the top half of the United States seems to, in general, do better than the bottom half of the United States. So I live in North Carolina, so I'm glad at least we're light blue. But much of the Southeast, despite having the most lung cancer and the most lung cancer screening centers, so the most opportunity for patients to get there, we lag behind, less than, between 2.2 and 4.4%. With then, the Southwest in Texas and California, with Nevada being the lowest at 0.5. So 1 in 200 eligible patients is screened. So there's certainly a lot of opportunity for improvement. With COVID, everything, of course, is screening ground to a halt with everybody, right? We're up and running again now with protocols put in place for improving patient safety and staff safety. But, the CHEST expert panel was, led by Mazzone, was published in CHEST recently, asking 12 questions, really, from delay in initiation of screening. So their opinion was asked, do you think this is something we should do? And, 24 out of 24 strongly agreed with that. But then as the questions went down the list, it became harder and harder to answer. And so the 12th question is, well, what about considering delay in treatment of stage 1 non-small cell lung carcinoma? So that's a harder one. Do we delay care in known cancer? So there, 15 of the experts said, yeah, this is reasonable. We strongly agree that we should delay care because, COVID is such a problem, where 9 agree. So I think it all depends on the setting you're in, though, of course, right? And when this was first available online, we weren't seeing much COVID where I'm practiced at all. So to me, this, this didn't apply to me at the time. We're starting to see more and more now because I'm part of the Southeast, right? And so we're starting to see a lot more cases where I'm at now. So now some of this stuff makes sense. So I think common sense would tell you that, hey, this delay in care is going to make a difference for patients down the road, right? And so just conceptually, that makes sense to me. But 2 weeks ago, there was an article published in Lancet, so July 20th to be precise, that looked at the United Kingdom, looked at England, and wanted to do a modeling study and estimate what kind of impact shutting down the screening programs and delaying lung cancer care would have. And essentially what they were able to come up with, and I'm certainly not a mathematics modeling expert, but what they were able to come up with was approximately a 5% increase in deaths over a 5-year period as a result of what's happening right now. So, and that's, to me, that's not surprising. And I don't know if that's surprising to anybody. If anything, I thought it potentially would be higher than that. And the gains that we've seen in mortality in lung cancer being erased, unfortunately, because of what's currently going on. So thinking about how we manage the nodules, we've always, with incidental nodules, relied on the ACCP guidelines, the BTS guidelines, Fleischner Society guidelines for many of us. And then screen detected nodules, we're talking about lung RADs primarily, and then of course NCCN guidelines. But that leaves, just watching these guidelines, it's easy. The guidelines are very straightforward when you think about the 2% of patients that are very low risk defined as less than 5%. That's easy. We'll follow these with the CT scan. And it's also easy in the high risk patient population, which is 26%. Where it's not easy, though, is in the middle, the low to moderate risk patients, which are 5 to 65% risk, calculated by the Mayo Clinic Risk Calculator, and there's no clear guidelines, right? And it turns out that, number one, there's a lot of nodules, as Leah was alluding to, that are found incidentally. So 600,000 lung nodules between 8 to 30 millimeters with low to moderate risk are found in the United States per year. So a ton of these things. And most of those are found incidentally. But here's the sobering thing, and I think this is very true, that 2/3 of patients do not receive clinical follow-up. Now, back in 2011 to 2013, my ex-partner and I, Jen Mattingly, embarked on a project to kind of see how our patients in the healthcare system we worked at, how we were following these patients. And what we found doing a retrospective chart review, and Jen did most of this work, so I'm giving her the credit, is that only 19% of the patients were followed appropriately. So it kind of mirrors almost, or it was even worse than this stat that 2/3 of patients do not receive clinical follow-up. This is the exact reason why lung incidental nodule programs are started, and the reason why software to manage incidental nodules is needed. Because what we've also found over the years is the more humans are not involved in this, so you can automate it, the better off these systems, these programs work, and the better care patients get. So for LifePoint, which I'm employed by LifePoint Health, with 88 hospital system, every single hospital in the system is either using EON or will be using EON, because the healthcare system as a whole understands the importance of carefully tracking these patients so we don't lose patients to follow-up. It's a win for the healthcare system, and certainly a win for the patients to utilize a system such as what we're using. So in the patients that are this big black circle, which is most of them, so the question is, what is next for these patients, right? So Nicole Tanner and her colleagues published a study in Chest in 2015, in which they want to know, hey, what are community pulmonologists doing, right? What's the frequency of procedures? How are they following these patients, right? So the patients in this study were 40 to 89 with a pulmonary nodule 8 to 20 millimeters. What they found, I think, to me, is sobering. So they risk stratify these patients into low risk, intermediate, and high risk. Again, the same percentages that I just showed you. But regardless of what risk they fall into, you can see the same percentage receive surgery. So whether you're a low risk or high risk, you're just as likely to go for surgery. Whether you're low risk, intermediate, or high risk, you're roughly you're gonna get biopsied at the same rate, with the exception that the high risk get biopsied more often. Now, if anything, I would expect that high risk at 49% would be where the intermediate risk would, and the 32% would be in the high risk. So I think that would be flip-flopped. And then lastly, surveillance, right? 34% of patients in the high risk category were just told, hey, come on back for a CT scan at a certain interval, right? So I don't think this is how any of us envision managing pulmonary nodules, and certainly there has to be something better than this. You know, and there's, you know, a cost to being too aggressive in managing these nodules. So if you take a low-risk patient, subject them to a procedure, well, you're going to have a complication rate. So when the NLST was published, the complication rate was 8.5 to 9.8%. However, if you look at what really happens across the country, on a cohort of 344,000 patients, it looks like the complication rate is nearing 25%, which has a significant cost associated with each and every single complication. So there's definitely a cost to, a complication cost to being too aggressive. And so what that translates into, if you look at all the biopsies that are done, the surgeries that are done, pretty sobering statistics in that 43.1% of the total diagnostic cost of evaluating nodules is due to biopsy of patients without lung cancer. 69% of biopsies are performed on benign nodules, so a ton of procedures that did not need to be done if you could look into the future somehow. And then 43% of surgeries are on patients who end up with benign disease, which is always nice when when someone wakes up from surgery and they say, well, Mrs. Jones, good news, no surgery. But that's a really, really hard way to find out, or excuse me, no cancer. But that's a really, really hard way to find out that you don't have cancer. Now, on the flip side, there is a potential cost to being too conservative with these patients, right? So, well, wait, I don't want those complications. And, I don't want to biopsy patients that have benign disease. Nor does anybody, right? But if you're too conservative and follow patients that you should be more aggressive on, you lose your opportunity to have good outcomes. So I want to focus you on, the 5-year survival, just like the 1A1, 1A2, 1A3. So 1A1 is 0 to 1 centimeters, 1A2 is 1 to 2 centimeters, 1A3 is 2 to 3 centimeter nodules, right? That's what that is based on the staging. Now, it's not too hard to think that if you see a patient with an 8 millimeter nodule and you say, you know what, we're going to just be very conservative here, and we're going to see you back in 3 or 6 months with the CT scan, that 8 millimeter nodule, if it's cancer, went to 1.2 centimeters. So what just happened there is their 5-year survival decreased by 7% in waiting, right? And so you can keep on going down the line and doing that, but the problem is it takes 8 months for a nodule to be diagnosed as either malignant or benign. Now, I was at, we had a conference for the Society of Advanced Bronchoscopy, and Otis Rickman was on the stage, and he made a statement that I'll probably always remember, that general consensus is it generally takes 3 months of waiting for a stage shift to occur. Now, whether it's exactly 3 months, but I think the point is well made that, hey, this is an urgency to move on these patients. So the million-dollar question is, well, how do we do better, right? So our job is to take that black circle, which is the biggest percentage, like 72% I showed you a few slides ago, and shrink that down to almost no patients and move all those patients either into less than 5%, so low risk, or into the high risk. And ideally, that would be a bigger number than 65%, right? It'd be great if it was like 90%, greater than 90%, that all the patients are residing in one of those two things, because then management of these patients becomes easy. So I think the path to that is a couple of things that are currently available and a couple of things that I think are emerging. The two things that are emerging and used a little bit, as Leah was alluding to, radiomics and artificial intelligence. But the things that are here are biologic response assessment. So how can we use biology, either protein analysis or antibodies, to determine which nodules are more at risk or less at risk? And then procedurally, how do we do better procedures that lead to less complications but yet higher yield? So how do we serve our patients better once we find something we want to act on? So the first thing is radiomics. So what's the promise of radiomics? So the promise is the phenotype of the lesion represents the biologic behavior and the genotype of the lesion, right? Simple as that. So, what it has the potential to do, and this is just the underscore potential, because I'm not saying we're there yet, because we're certainly not, but it has the potential to diagnose cancer, identify mutations, predict prognosis of these patients, and predict response to therapy. Because what the machine could do, i.e. the computer, whatever, is see things that the human eye can't see. So a CT of the chest contains 9 million voxels, with a 5 millimeter nodule containing 130 of those voxels. So a CT scan can see, or the computer can see many different textures and variations that the naked eye cannot see. So that's essentially the gist of it. So with radiomics and lung cancer screening, so one of the problems of lung cancer screening is a really high false positive rate. We see a ton of nodules, most of which don't end up being cancer, but we need to follow these, right? And patients are nervous. So using radiomics, in the trial, published all the way back now, I guess it's getting old, in Journal of Thoracic Oncology in 2016, decrease the false positive rate to 9% with an 80% accuracy. So certainly there's the potential to use this as a way to further decrease the false positive rate of lung cancer screening. The utility of radiomics, and I'm certainly not going to go, this is a 20-minute talk, so we can't get into all this, but there's been increasing amounts of literature published on prediction of malignant nodules better than radiologists, predict response to chemotherapy, predicting mutational status. So, the strongest data is probably on EGFR mutations. So nothing like taking what data you already have. So you already have the CT scan. You're not drawing blood. You're not doing a procedure on somebody. You can just analyze data that's already there for a CT that most of the time they got for some other reason, not even for thinking about cancer. And you can say, well, this nodule is likely to be malignant and it's likely to be EGFR positive. So I think, to me, if we get to that point, that's going to be awesome. So kind of related to radiomics is artificial intelligence. So, the concept of convoluted neural networks came into being, in roughly 2012, and is the ability to see patterns that are beyond human perception. But with artificial intelligence, it's been largely a marketing term, essentially, because what you need is these huge databases to train the computer to be able to perform the way you want it to do. And so this development of these convoluted neural networks coincided with these big databases. So the NSLT database, the Nelson database, the Lung Database Consortium image database are all things that these artificial intelligence programs have used to train themselves. So we've come a long way recently as a result of this. So, and then of course, when Google does something, it makes the news, right? So Google said, all right, we're going to build a program, artificial intelligence. We're going to train it using NSLT, and we're going to compare ourselves to 6 board-certified US-based radiologists and see who can predict cancer from a nodule at the 1-year mark better, right? And so they did that, and guess what? Google, their artificial intelligence, won. So they detected 5% more cancer, 11% more likely to reduce false positives, and with the exception that is if a human being had an old CT scan to compare it to, they got just as good as the artificial intelligence. So then, the question is, well, is that the end of radiology? Well, it's not quite ready for prime time for a couple of reasons. Number one, and probably the biggest reason, is that Google states that their code has dependencies on internal tooling, infrastructure, and hardware, and its release is not feasible. So there's no chance I'm getting this at my hospital is basically what that says. And furthermore, the radiologists reviewed lung rats, which is a management tool, not a predictive tool. And so if you, in a separate study, if you ask the same radiologists to upgrade nodules to 4x, if they thought they were cancer, radiologists were able to move many of the nodules that they gave lower lung rad score into what they thought was cancer, and we're better at that. So, so anyway, I think it holds a ton of promise, but probably not quite there yet, especially for mainstream use. The thing that is here, though, and the thing that I'm incorporating into my practice is biologic response assessment, right? So both proteomics and immune response. So what's needed, I think, when you're looking at pulmonary nodules is you want to see this pulmonary nodule. You want to calculate using, like if it's an incidental nodule, using the Mayo Clinic risk calculator, get your percentage, right? And that's your starting point. But then I want to either be able to have a rule out test to decrease the risk, or I want a rule in test. So something with different performance characteristics. And so that's exactly what we're doing. The rule out test is what we use for likely benign nodules. So the one that's commercially available that we're using is the Nodify XL2 test. And to my knowledge, this is the only test like this available. So what this is using is it's using the same characteristics that the Mayo risk calculator uses. As you can see there, the 5 clinical risk factors. And then it's using 2 plasma protein levels, so the LG3BP and the C163A, to calculate your risk of, predict your risk of malignancy. So this was published in Chest in 2018. It's Silvestri's paper, and the characteristics of this were 98% sensitivity and 97% negative predictive value. So let's say, again, I have a nodule and its pretest probability is less than 50%. I'd run this test. Now let's say I run this test and it doesn't change. So it's still sitting at, let's say, 18%, my risk. So then if that doesn't change, I could then flip and say, well, now what about rule in, right? And so that's the other side of the equation. So a rule in test for likely malignant nodules, right? So this is now an antibody test. So it's looking at it's a 7 antibody panel looking at antigens to detect lung cancer across different histologies. So you can use it for the different non-small cell histologies as well as small cell patients. Now this, instead of having a really high sensitivity, it has a really high specificity at 98% because, again, it's a rule-in test. And so we're often using these tests in reflex to help modify risk of the nodule and then use that as a decision-making tool with the patient so they have more information to make good informed decisions on which path to take as far as management of their nodule. So then lastly, what I just want to touch on, well, now that we found these nodules, now that we say, well, Jesus could be malignant, we need to serve our patients well by doing good procedures on them, not giving them complications, and having a better diagnostic yield than historically what we have had, right? And I think that those days are kind of here, right? And so what we've learned, and BHADRA is really an expert on this, is and what we've learned really over the past handful of years is, hey, when we do procedures on people, they get ATELECTASIS. And so when we're trying to biopsy these little nodules, we do a 3-dimensional map and a CT scan. We're trying to use that data, incorporate that with the real lungs, and then be able to biopsy these things accurately. But due to a concept called CT to body divergence, oftentimes our roadmap does not match reality. And so we may be trying to biopsy a nodule that's 1 centimeter, but if we're 2 centimeters off, that's a big problem, right? So our diagnostic yield suffers, the risk, our length of procedure goes up, complication rates go up, and diagnostic yield goes down, right? And so what we need to do, and what a couple companies have kind of figured out, is how to correct for the CT to body divergence in real time so virtual becomes reality. And this is just a slide saying, hey, this ATELECTASIS occurs in a lot of patients very frequently. So, the couple companies that have come up with a solution to this are the either using digital tomosynthesis, and that's SUPERDIMENSION, in which using an algorithm and subtracting out data to accentuate where the nodule is, and then marking the nodule and doing another registration, a local registration, to make sure that where you think you're biopsying is reality. One of the big advantages of the system, and this is from a procedure I recently did on an 8mm nodule right underneath the rib. In that upper left panel, you can see it's right underneath the rib, is being able to look right down the barrel of the gun, essentially, know exactly where you're biopsying, knowing that that's reality, and being able to stay on the medial side of that nodule so you don't give the patient a pneumothorax. So the second system that really is able to correct for the CT to body divergence in a real way is the body vision system using augmented fluoroscopy. So this is kind of related to digital tomosynthesis, but different algorithms and a different technology to make sure that when we're biopsying, what you see in the middle panel, the yellow, all that is where the real nodule is. And again, virtual equals reality. And one of the really nice features of the system is on the right panels, you see you can get CRM-based tomosynthesis, so you can actually see your tools in the lesion. So this is much like you would with a cone beam, which are static images when you do that. And so I think these are two examples of moving in the right direction as far as improving diagnostic yield. And then lastly, the last slide before the conclusion slide is, all right, so these companies are getting better. Now it's time to take on, which has always been the gold standard for peripheral lung nodule work, which is CT-guided needle biopsy. The downside of that technology, of course, has always been complication rates, meaning pneumothorax rate between 20 to 40%. So using the Illumicite, which is the SUPERDIMENSION product, there's a trial that the Vanderbilt group is the investigators on, in which they're going head-to-head using navigation bronchoscopy versus CT-guided needle biopsy in a randomized trial that just started enrolling patients in May of 2020. And so I'm really looking forward to that, but it's exciting to be in a time where you can start to think about a bronchoscopy technology going head-to-head with CT-guided needle biopsy, because I think at the end, as this technology all improves, our patients win. So with that, the conclusion is, using both the emerging and existing modalities to more accurately risk stratify patients will lead to, number one, decreased complications and diagnosis of lung cancers earlier, so early stage, and then ultimately the goal of us all is to improve outcomes in lung cancer. So with that said, I am going to turn it over to the Honorable Dr. Krish BHADRA.
Thank you very much, Scott. That was great. I'm going to now share my screen. Can you guys see that? Perfect. So I'm going to talk a little bit about a case study in thoracic oncology and program development. And we've heard a lot of exciting opportunities, both with software, programs, but one of the questions we always face is, how do we start one? How do we get one off the ground? And if you're already started one, how do you become more and more successful? So one of the things is that we're here talking a little bit about incidentals, but you've got to build your CT screening program. But identifying IPNs is key. So one of the things that we recommend is that if you're just starting off and you don't have the funds for one of the more adept software programs, is to simply have your radiologist tag the scans. So approximately 6 or 7 years ago, a lot of the key role players went and discussed this issue with the radiologists who were seeing lung nodules on a routine basis. And they would just simply mention that there was a lung nodule, but not make any specific recommendations. And so we started to ask them, can you make recommendations, follow Fleischner guidelines, follow lung rads for screening scans, and then lastly, we asked them to tag them and saying, consider pulmonary consultation or follow up with an established pulmonary physician. So we went through that process, and so what we noticed is right away we started to see an increase in the number of referrals for these specific lung nodules. And Dr. Skibo had highlighted that almost 2/3 of these patients that have these lung nodules are completely lost to follow-up. And so it's in vital importance to be able to tag these patients. And so when you're trying to build a program, one of the most important things is to identify the key role players. You're not going to be able to build a thoracic oncology program without the most important people in the room being there, which is a lung navigator, having a thoracic surgeon, having medical and radiation oncology, participate at the same table and be included in that discussion. And with that, you can have a divide and conquer approach, or you can develop a leadership team and have a medical director and have a line of duties that are assigned to each single person, or just work together. And I think when you get everybody on the same page, you don't see some of the fragmentation that can occur if everybody is working in their own silo. And as a group, you can achieve more. One of the things that's also important is highlighting that there's some sort of, I don't talk a lot about financials today, is that understanding that CT screening is the only form of reimbursement that you can obtain for a patient, for a provider for screening. So a provider isn't reimbursed for prostate cancer screening, breast cancer screening. Unless you're a GI doctor, you won't be reimbursed for colonoscopy screening. So essentially, it's the only form of screening, but you've got to be able to fulfill the required entry points into when you're trying to set up a patient for CT screening. And so this is something right from our CHI hospital system. You can take this, it says draft on it, but then you can also automate this and put this into your EMR. And we have it somewhat built into Epic and Allscripts. And so patients can be easily ordered or flagged if they qualify for CT screening. One of the most important goals is in the background, is to constantly educate our primary care physicians and offer formal administrative assistance to be able to get the message across. I know that I've spent countless numbers of hours, and sometimes it takes innumerable visits to a primary care physician to be able to change behavior. And that takes time. And so you heard that 4% of the nation, which is the high number that we quote, 4% of patients who are eligible for CT screening actually get CT screening. And when you start talking about this CT screening, there's always this question, we're putting in all this effort. Is it really worthwhile? Are we going to get anything out of this when you talk to an administrator in terms of, other than saving lives, which is, the main goal of it, this reduction in 20% mortality rate, which we're going for this high risk population. So what we did is in 2014, in the fiscal year, we looked at the number of screens we had done at that time, which was 294 screens. Only 3 patients were positive for malignancy, which is about the current rate of 1 to 1.5% based on the NSLT data. But essentially, you can see these this itemized account. So we had utilization of services in the neighborhood of 265,000. The cost of those services was 43,000, and then the reimbursement that was received to date. And this was halfway through the year when there's rolling billing being taken into account. We were breaking even at just 294 screens. And these patients are getting, the downstream includes lung biopsies, inpatient admissions, radiation therapy, PET scans, even sleep studies, so on and so forth. So there's a whole litany of things that occur once a CT screen is done that results in downstream, not just payment for or the direct contribution for that CT screen. So I'm going to take a step back here. So I've given you a little bit of insight into how to start a program, who to identify, who to team up with, and how important it is. I'm going to talk a little bit about the way we've set it. This is kind of a busy slide, so I'll walk you through this. And so we talked about the software programs. Now, this talk is essentially vendor neutral. So I think if you have a software program, that's better than not having one. And remember, even if you have a software program, you have to have appropriate number of FTEs for the size of your system to be able to input all that data. So it's not as easy as just saying, I'm just going to get a software program. And then not only that, you've got to make sure that you've got a software program and that it interfaces well with your current IT. So even if you have a fantastic software program that's available, it needs to be able to interface and be able to take advantage of all of its features. So Chattanooga, we were the first site with the help of Rob Hedrick, my thoracic surgeon. He started a project with Think Health, which we were the first site for natural language processing to be able to try and track CT scans using data analysis and looking at the actual reads themselves and identifying them and tracking them. And so you can put in your own software system of choice, a database and primary care, and then you feed all of those patients through one centralized clinic or phone number. And so, to make things really easy, I remember sitting around one day and I said, well, why don't we use our prefix and then we add the word lung to it? And so that seemed to work. So we used 495 lung. So if you're at the early stages of this, don't waste a whole lot of time. That's something that you can probably obtain within your own hospital system. You have to build these programs around brick and mortar type clinics and or navigators. And so there's an intake process for data entry. And so if a patient comes in, gets identified as a potential screen or an incidental, a navigator or a patient and the clinic will then will decide whether or not they have appropriate funds to be able to go after a scan. If they have an abnormal scan, we always allow that the primary care physician or whoever the ordering physician for that scan is to determine which way they're going to go, whether they're going to go to your clinic, an outside hospital, or a outside pulmonologist. Either they're lost to follow up. And a patient who has a normal scan, refer them back to clinic for surveillance. And then there's always going to be, a repeat annual scan as well as a loss to follow up for those screening scans. And those patients who don't really qualify, they can go for direct marketing if they so choose. So this is an example of some of the data that we can analyze, and this kind of sheds a light on how important or how powerful this data set is that can show that, where we were building our CT screening program is that you can see that every year over year we had projected growth. And then we had a significant bump in the amount of screens that we had in 2018. It'll be curious to see what happens with COVID in the future, whether these numbers are going to decrease and how much they're going to decrease, and then how long is it going to take for us to recover. So when you're getting a CT screening program, you know, it's always going to be about thoracic oncology, and you're going to try and make that, that known. But there's another component to this, is that when you're doing CT scans for patients, you're going to find other findings that are going to lead to other subspecialists getting involved. So it's not uncommon for us to be able to see that there's a large number of patients that have coronary artery disease, or they have pulmonary fibrosis, or another form of mass, or an aortic aneurysm that needs to be operated on. So there's a whole litany of options for the potential incidental findings for these patients that will be another source of revenue for the system. So one of the things that's also important is that a lot of people don't realize we use these lung rads for CT screening. And of course, you've got, you know, lung rad scores 1 through 4, 4B. And then you can also have this S modifier. And S modifier is where they have another significant finding that requires follow-up, and those patients then can be identified. So lung rads and CT screening is not just for thoracic disease, thoracic oncology, it's also for cardiac disease, and it's also for other significant findings. So that's something to take into account when you're looking at the impact of downstream revenue. Another aspect that we started in Chattanooga, we were one of the first sites to develop a mobile lung screening CT bus. And this is really credit to my thoracic surgeon, Rob Hedrick. This is fantastic. The amount of effort that he put into this was really astonishing, and he's a good resource if anybody out there wants to look into this. So this is a new concept to most people, is that you've got this bus that instead of having patients have to come to us to get their CT screens, we can send the bus out to them, and then they can get their screening scans out in the community. You know, but one of those things that once you buy a bus, you've got to have a practitioner, you've got to have electrical, you have to have garage support, but it is a moving billboard, and it has a great advantage that, you know, a patient doesn't necessarily have to come to the hospital to get their scan. One of the things from a business perspective, if you're trying to build your thoracic oncology network or practice, is to understand that it's obviously going to have the most important players, which are medical radiation oncology, thoracic, in your pulmonary groups. But you're going to also have to build on primary care. And I think that's where the early recognition of these lung nodules is going to take place. And it's upon them to build a relationship with, or it's upon you to build a relationship with those primary care physicians so that they're aware that you have a lung nodule program. So now let's flip this around. Let's talk about the patient experience. And there's really 3 time points in a patient's experience: discovery of a lesion, diagnosis, and treatment. And so we talk a lot about, you know, that there's long wait times. So Dr. Skibo had mentioned that on average, it takes 8 months to get a diagnosis or treated for lung cancer. And that's really inexcusable. And a lot of that is, you saw in the data that we're watching patients with high-risk lesions. And so it's really important that we try and figure out a way. So this is kind of insight into our model or way I practice. And so it gives you an idea that there's a lot of things you can do to help fix that. And so one is discovery of a lung lesion. So that means if a PCP doctor, a specialist, or an ED doctor, or a self-referral occurs, there's really 3 options to be able to get that patient from discovery of a lung lesion to a workup. And that's really, you can fast track, you can send them direct to bronchoscopy or direct to CT guided FNA. I allow all patients who are coming from pulmonary physicians and my surgeon to go directly on a schedule. There's no, we don't put another roadblock in front of them. We want to get them through our system as quickly as possible. I trust my pulmonary colleagues, I trust my thoracic surgeon, and they do a good job. And I do a hard stop. If something changes in the patient's status, we'll stop that person from going forward with a procedure and then redirect appropriately. Now, there's 2 other options for nodule clinics. One is a virtual clinic, that can be distributed throughout the clinic. but that you recognize to and you explain to the community that you have a lung nodule clinic. If you have a mid-level, you could use a mid-level to have a 6 millimeter cutoff. So essentially you would say, a lot of these lung nodules are smaller than 6 millimeters. We're really not going to do a whole lot with these nodules. We know that we're probably just going to surveil them, and then they can, you can go and see a nurse practitioner and be safe that there's not a reason for intervention. And if you feel confident in your nurse practitioner or your PA, you can move forward with having them evaluate and work with you. Now, and then the other option is a brick and mortar clinic. And that really is the best model if you can build it. Now, it's not feasible for a lot of people, but if you can build a dedicated provider clinic surrounding lung nodules, that is the gold standard, I think, in my mind. So that's something you can shoot for as you're trying to develop maybe the other sides of this, which is a fast track program or a virtual clinic. And then we talk about diagnosis. That's another time point in that patient's experience. And so here we have, and this is a busy slide, so I'll just break this down. But this is where the lung nodules are coming from, your CT screening program, some of the upstream players, and then they go through a pulmonary clinic, an interventional pulmonology clinic, they go through a thoracic surgeons or some sort of lung nodule clinic, and then they need a diagnostic procedure. So they have a diagnostic procedure, they have some downstream with anesthesia, pathology, fluoroscopy. If they're negative, they go back to surveillance. But if they need a repeat biopsy or if they have positive, a nurse navigator gets involved at the point of diagnosis. And there's a lot of individuals who care about lung nodule patients and thoracic oncology patients. There's genetics, there's multidisciplinary lung tumor clinics, there's medical radiation oncology, there's thoracic surgeons, there's pulmonary, there's all the interventional folks, pulmonary, GI, radiation oncology, palliative care, hospice. And what we are trying to do is to take that time point, instead of being 8 months, 9 months, 180 days plus, is to contract that. And then we had a recent survey done by the COC, and we were 3 weeks from the time of discovery of a lung lesion to treatment. And that's really what we're trying to do, is to get them to that time point where they're actually treated. Now, this is a really revealing talk, because this is about a little bit about what it takes, what kind of grit it takes to build a practice to be successful. One of the things is, this is going back to 2012. I'm going to give you metrics over 4 or 5 years and to varying degrees over the next few slides. But I'm going to talk about, what it takes. So you'll see here that back in 2012, I really didn't do a whole lot. And then as we go along, there's some cyclical component. I'm on vacation. I'm not doing as many cases or procedures. And then as time goes on, there's an inflection point that occurs, and then there's a ramp up in the number of procedures. And so by 2016, we were doing a fair number of cases. You can see that the moving average had moved up. And as a result, we get busier and busier. But what's also interesting is that in 2000, this is an annual look, 2012, 13, 14, and 15. And what I want to show you is that, look right here, in 2012 and 2013, I was hovering around 300 procedures. And you say, okay, that's a high number for anybody, but you didn't really grow, you didn't really change. And this is something that's really interesting to understand if you're building a lung program, especially if you're a pulmonologist you start off, or even a thoracic surgeon, is that you start off with these low volumes, and then you try and say, okay, well, you're trying to build, but you're not making much of a difference. But when you start to look, these are CPT codes, and these are the financial metrics. CPT codes, for those of you who are not familiar, are charges that are associated with particular procedures. And so this is just the number of CPT codes per case, not per case, but total and per year. And so in 2012, I was a colossal waste of money. I did 300 procedures and on 311 CPT codes. I mean, that's not financially viable in my line of work. And so, but from 2012 and 2013, where I still did the same number of total cases, the CPT code started to increase. This concept is disease complexity, and that's important to understand as you're you want to be able to do more complex cases, more better procedures that are more minimally invasive, and so on and so forth. And so you'll see, as we went from 311 to 2,547 CPT codes from 2012 to 2015. And then you say, okay, look at this. This is the charges per year, including procedural codes and E&M evaluations, which is basically like clinic visits. And that increased from 289,000 in charges. This is not collections, by the way. This is just charges to 2.24 million. And this graph ends in 2015. And this sails through, you know, significantly higher as we go on. But one of the things to say, okay, well, Dr. Budge, that's great. You're getting busier. You're doing more complex cases and you're charging a lot more money. That's great. But I'm not trying to show you that, you know, that you're, you know, that we're making more money. I'm trying to show you is that look at that slope. Look at that growth. That looks like it's shot out of a cannon and just increasing significantly. And so this kind of shows how powerful this data set is as you kind of move forward and build your program. Now, one of the things that's important is when you're talking about your growth as a program, the C-suite or the CEOs are going to want to know, what are you doing in terms of downstream revenue? What are you building? What is it? That's great that your practice is busy, that you're doing a bunch of cases, but you know, what's happening? And so we'll go through that a little bit. And so here at Memorial, you know, most of the cases involving, this is a metric involving cancer patient procedures are really done by two individuals. My thoracic surgeon and myself are doing it. And we have, at this time, we had a number of also additional pulmonary providers that did do a significant number of cases, but the much of the volume was housed in the people who were vested, the key role players in thoracic oncology. And now, if you look at this, now this is the number of patients that underwent radiation treatments, not one patient, 30 treatments, but one patient, 430 treatments. So in 2012, this is when I first arrived, there wasn't a whole lot of radiation going on at Memorial. There was only 31 patients with lung cancer that got radiation treatments, and then that increased significantly, almost sevenfold to 224 patients. And so that's a significant volume in the increase of patients undergoing radiation therapy. Lung cancer surgery also increased about 27% during that process, and that continues to increase as well. And then here's another aspect. A lot of people are saying, okay, you know, here comes an interventional pulmonologist, and we're going to stop doing interventional radiology procedures. We're going to stop doing CTFNAs. Well, that anything can be further from the truth. While I was increasing, you know, sevenfold, their volume also increased 40% over 5 years. And so what's interesting is that as you build your lung nodule program, as you build your thoracic oncology program, the narrative is that you're going to grow if you're a pulmonologist, your thoracic surgeon's going to grow, your interventional radiologist is going to grow, your medical and radiation oncologists are also going to grow. And that all makes sense. This slide is an incredibly important slide that I want to kind of bring to your attention. And this is really powerful because not a lot of people have access to this, but this is talking about, you know, what's the contribution margin for all of these procedures associated with EBIS, EBIS-NAF, and who did them and so on and so forth, and what happened to them and how much downstream was associated with. So we had, the first thing I'll show you is our thoracic surgeon increased significantly, almost up to $1 million in contribution margin, and now is significantly higher than that. And then in terms of, from 2012 to 2015, the pulmonary group increased, almost tripled, 722 to 2.14 million. And then you have the radiation oncologists. Remember, I was telling you that the radiation oncologists weren't doing much, but they went from 176,000 in contribution to 1.194 million. Now, look at what happens at the bottom of this slide. 2012, 2013, 2014, 2015, 1.6 million. The next year, 2.5 million, then 3.7 million, then 4.3 million. This continues. And what's really important for everybody on this call to understand is that this isn't just gross money. This isn't, this is contribution margin. This is pure profit for the institution. And so that's incredibly important. So these patients, you know, they're valuable in terms of the economic viability of an institution to support, you know, investing in software programs for nodule development, nodule tracking, to have a robust CT screening and incidental program, to have a robust, you know, operative environment so that your pulmonologists and your thoracic surgeons can thrive. And all of the downstream players benefit from this, and you can see this. And so when you're talking to your C-suite, if you can collect this kind of data, you can show year-over-year growth, and then you can show that they're actually profiting from this type of intervention. Now, I always get a little uncomfortable talking about financial metrics when it regards patient care, you know, but this slide really captures everything. And tells you exactly what this means. So we talked a lot about how my practice has grown, everybody else's practice has grown, the hospital, a lot of more treatment of lung cancer patients have occurred, and more surgeries, more radiation, and more downstream, and so on and so forth. But look at this. So every hospital has a tumor registry. And so if you go to your hospital, and, you know, if you have a tumor registry, you can ask, it's usually published nationally on a 3-year delay, so our numbers are public. And then here you can see that this is from 2012, 13, 14, and 15 to 2016. And you can see that this significant change occurs. We start to see what we call as a stage shift. Instead of seeing patients that are stage 3 and 4 predominantly, we see earlier stage lung disease, in particular stage 1 lung cancer patients. And those patients that can get life-saving surgery, they can get SBRT, and they are now cured. And that's important to understand, that there is, in the end of this narrative that we talk a lot about the financial metrics, is that patients' lives are actually being saved. And you'll also notice the stage 4 numbers have also significantly decreased. So we were at stage 1 and stage 2, just to kind of go back on that, we're 52%. We're hovering around the 50%. As we grow our program, we're hoping to see that kind of shift over as the CT screening component. And while we don't know what's happen, we would hope that that would start to shift, and maybe even be, you know, cancer could become a chronic disease process that we manage. Prevention, both on the front end and on the back end in terms of treatment, are evolving. Now, one of the things that's kind of interesting, and this is, I added this one last slide before we kind of close out, before the final slide, is in about 2 years ago, and this is with the help of the folks from Lung GPS and Emily Villas, who helped me with, and she's a healthcare economist. And so we were looking at some of the financial data, and we're discussing some of this. And then in the last couple of years, there's been this addition of what we call a complexity adjustment. APCs are codes that are ambulatory payment classifications, and every code is, every procedure has an associated CPT code. So on the left, you see the CPT codes, and then you'll see a primary APC assignment, and then a secondary code. And if these two codes are attached, then you can up classify and add in a complexity adjustment. So I just talked a lot of mumbo jumbo about coding, but the bottom line is, instead of traditionally being reimbursed for just the EBIS or just the NAF, now you can add in this complexity component, and then you can see a significant uptick in your reimbursement. So your rate increase would go from, you know, $1,400 to $2,900. If you're doing EBIS and NAF, it would go from $2,900 up to about $5,440. And this is Medicare. This is approved. This is public information. And I encourage you to reach out to somebody from the Go To Lung Cancer Foundation to get more metrics and more information. On that note, I'm going to, right before I close out, this is not a slide that we're going to digest in this talk, but take it as it is. This is a SWOT analysis looking at strengths, weaknesses, opportunities, and threats, both internal and external, and how to think about these types of things as you try and figure out and what your obstacles are for success from a financial standpoint and to grow your program and to be able to frame that. One last thing is Kim Barham is going to, I'm going to stop my portion of the talk and then hand it over to Kim. She's going to talk a little bit about the financial calculator that the Go-To Lung Cancer Foundation has worked on. This has been a multi-year effort and will hopefully provide a lot of information for the LCOEs in the future and really advance thoracic oncology and the cause for our patients.
Thank you so much, Dr. BHADRA. And I want to thank you for your time, not only for this evening, but also all last year, helping us create this business model. This is truly a labor of love for all of us. We really want to have more lung cancer patients diagnosed early. So we know to get that, we need to have the resources at the front for early diagnosis and early detection. So we're creating a model that is, and we've got it already available, free source, free for anyone. Just reach out to me. But we need institutional scans, your number of lung cancer screening patients, and then your expected growth, patient capture rate in terms of do you have all the systems in place to take care of your patients? Do you provide thoracic surgery? Do you provide stereotactic radiation, CyberKnife? What your whole lung cancer continuum program? Then we look at the infrastructure effectiveness. Do you have the ability to identify patient nodules and follow them up, and have it software that will help the navigators when they're having to do all their follow-up? And then any infrastructure cost. So your FTEs, your software, any hardware or other costs that may come down. We do have assumptions built in, but it's always better if we can customize it. So we can do that. When we plug in all your numbers, then you will get out a really nice report that you can take to your CFO, COO, or whomever could help do a deep dive pro forma and get you the resources you need. And this is really valuable right now when you are struggling, and most hospitals are with the furloughs that have happened. This brings value to your program in your hospital. And please reach out to me anytime. We're here for you. And then I just want to end right now on a note that we will be having another webinar next week. And it's from 3 to 4 about resuming lung cancer screening amid COVID. And you can register if you've not gotten the invite at screening@go2foundation.org. And you can see the presenters there on the screen. And I don't know how much time we have left. We have time for questions. Let's see, Dr. BHADRA and Dr. Skibo, are you available for questions?
Yes.
Yeah, absolutely.
Okay. We've got a few that have come in that I would like for you to acknowledge and address. One is that they are starting to try to explore improving process for identifying coronary artery calcifications. Could you address this, risk factor algorithms and incidental findings?
So I think we've looked at this a little bit at our institution, and I know Rob, who's also a thoracic surgeon, happens to be a cardiothoracic surgeon, so that's really quite helpful to kind of communicate the importance of being able to identify coronary calcifications. Now, you can do both if you have an appropriate low-dose screening, but you have to have institutional buy-in, you have to have them overread, you have to have them read by the appropriate types of physicians, and it can be done. And if you were able to incorporate that then you can easily capture those individuals and then send them in an appropriate manner. But if you build a platform and you find the key role players, I think it's absolutely doable, and it's actually a pretty good benefit to a patient if you can do both at the same time. Scott, I don't know if you have any insights. Have you guys looked at that?
I agree completely, Krish. I concur with your answer, absolutely.
Right, and we do have built in the business tool, the significant findings with the S factor. So there's a lot of cardiac calcifications that truly are identified as well through screening, so that those could be captured in the performa. The other question is, does it make sense for an entire facility to adopt LRADs versus Fleschner's if there's already an IPN program in place?
So we restate that question, Kim. I'm sorry.
Okay. Does it make sense for an entire facility to adopt LRADs versus Fleschner's if there is an IPN program in place?
Well, you're really talking about two things. So lung RADs is really talking about your screening patients, and Fleischner is really talking about your incidental nodule patients. So, we have a very comprehensive program in place for both of those things, and we use both lung RADs and Fleischner, for our patients. So they're really mutually exclusive depending on the patient population you're talking about.
Agreed.
Okay. And then you all both use different softwares. Can you expand on other softwares that you have heard that others are using?
I think a lot of people have, so first off, the programs that are out there between EON and Lung GPS and Think, they're all beneficial to your providers. I think it's a little bit of a matrix. You have to kind of think about what's going to be working for your institution, what your IT works with, and how well that software program integrates. I know that Dr. Skiba can talk a lot about EON. I can tell you that our experience with Think has been good for the most part. I think we ran into some significant issues of interface where the software program wanted to mine data and could provide these additional features, but we were going through, this is just real world things. So we have that capability. However, we merged with another company. We had a lot of firewalls that were put in place. So we didn't get to utilize all of the features that may be possible. And another misconception of these software programs is that they're totally standalone. No, you actually have to have a human being involved to make them work. And I think that's also important. And then it's a commitment. Once you start, it's almost impossible to move over unless you really have a really good situation set up in between to make that transition. But I know that the Lung GPS and EON are very good platforms. And I don't know if Dr. Skiba, I'm actually curious to hear, it's been a while since we've talked about this. And I heard that you said that you're going to be moving your entire system over to EON. And I'm curious to see how did that come about and what steps you took to kind of make that happen?
Right. Well, essentially it started as I was the first center to use EON, and we implemented EON at our program. And based on the success of our program and the success with this software company, LifePoint felt comfortable moving forward with nearly 90 hospitals and investing in that. I think but certainly, I think the important thing is not doing things anymore with Excel spreadsheet. I think that's a recipe for disaster. And, it just really is. And because it becomes overwhelming. Since I've looked at other software companies, it's been a handful of years now. And I know when Medtronic's product was coming, they didn't have a product yet. It was still in the beta phase when we went with and so since that time, I have nothing but good things to say, but I haven't really evaluated other products either because, what I have is working and we're happy with it as a system, but that's not to say that there's not other good things as you're using in your system, etc. So,
Yeah, I think
So of course,
the drive-home point is what you touched on in your talk was, to me, it's astonishing to know that 2/3 of the lung nodules that are detected are just completely lost to follow-up. So obviously, me sitting around with an Excel spreadsheet with 50,000 scans being done in our local system, there's no way that I can do that. So you're going to need that help. And so I think the message from Dr. Skibo and I, and if he agrees, is that, it's helpful, think about it. And of course, it's going to come with some sort of expense. So you're going to have to make a good financial argument for that to happen. Maybe try a beta site, try your particular center, see if that models correctly, and then roll out in a more broad approach like Point is.
Yes, and I will be glad to work with anyone and give them a list of any software vendors. It's their due diligence and what works best for them. But as you said, it's overwhelming, and you need a software to help manage those patients to make sure they don't fall through the cracks, even if they've been identified. A couple more questions have come in. We have started an incidental nodule program. We're into about 8 months. Wanted to know what kind of metrics are you looking at to gauge how the program is going?
So I can start with this, BHADRA. So, I think one of the things we've always wanted to look at is, number one, when we capture these nodules, how are they being managed? How quickly do we get patients in? We have a clock that starts from the CT scan, where we detect the nodule to when these patients are seen, and if appropriate, when a procedure is done. And then furthermore, once you're diagnosed with lung cancer, how quickly that happens. So, I'm always very interested in that time clock, because I think that's a marker of good quality patient care. So that's one of the metrics, that we're certainly, we look at. BHADRA, what are you, how do you look at things?
Yeah, I think that's the same metrics that you have to do. I think if the national average for discovery of a lung lesion to treatment of a lung cancer is in the neighborhood of 9 months, 8 months, that's embarrassing. And so when I look at that data, I say, no wonder people have advanced stage lung cancer, stage 4 lung cancer, because we're essentially either not following up on these patients or they're lost to follow up. And I think the components of detection and then getting patients to treatment with a diagnostic procedure and treatment is the best metric to look at that. And then you'll start to see, when you look retrospectively, that you'll see a significant stage shift. At the end of the day, our goal is not just program development and building it, but helping appropriately manage patients and then affecting the survival curve for lung cancer and stage shifting.
Yeah, and that is the ultimate metric that we're all following, is the stage shift in watching how many patients. You see an increase in the surgical patients, so indicating early stage disease, and as well as stereotactic radiosurgery indicating early stage disease. So you kind of compare that to what you did before your nodule program, and just about every program that does this right starts to see that stage shift pretty quickly.
Yeah, and I would recommend, if you know of, the Go-To Lung Cancer Foundation is, has a deep pocket of talent to kind of help you look through and find some good stories and good models to work through. One thing I would discourage you to do is to go on your own and try and build it on your own, because successful programs like Dr. Skibo's, and myself, I can be really honest, is that we're just 200 mistakes ahead of most other people. We've already messed up so many times, and seeing all the hang-ups, that we know that certain things work and certain things are better. So, and it's quite a humbling experience when you want change, you want to be able to do that, preach patience, and really go in for that team approach. I think that's the best way to do it.
Thank you. One final question. These are great questions coming in. This is from a lung nodule coordinator. Great webinar, so thank you to both of you. Any recommendations for enhancing PCP education for incidental programs in the early phase?
Well, I personally think
I'll take a stab at this. Go ahead.
Wait, you're going to answer this? Go ahead, BHADRA, please.
You sure? You sure? Okay. Thank you. So one of the things is that we found is that, boy, it's hard to educate a primary care physician. Mainly, it's difficult because, number one, you know, you're vying for a limited amount of attention, but to give them tools that to make it easy. So, you know, if you can find a way to flag it through their EMR, have a way of kind of hard stopping them to ask, hey, is this patient really qualify, yes or no? Education programs for your primary care physicians. I mean, and you can't just have one meeting when you just talk about it, because you're going to have to do it over and over again to make sure that they actually get the message across. One thing I will say is that it's really powerful if you can incentivize them and then let them know that they're going to get reimbursed financially with some sort of a metric. In our view, it's small, but it can be meaningful if they enroll a patient into a screening program. I see Dr. Skibo. Well, I'm sure you have a lot more to add.
No, there's really no doubt. There's really no replacement for face-to-face interaction with education, but not only the primary care physicians, which is to get the buy-in, right? You know, I found in going out and talking to providers, you know, they don't understand the difference between EBUS bronchoscopy, navigational bronchoscopy, right? So all those things and what you're trying to build, right? Getting them to see the vision. But then just as importantly is education in the community, right? Because if you have Mrs. Jones go in and ask her primary care physician about a screening CT scan, much more likely to happen than if Mrs. Jones doesn't even know about a screening CT scan. So I think we've done really a dual-pronged approach to education in Western North Carolina, both the patients and then as well as the primary care physicians. And we've seen, much like your numbers, you know, a significant increase year over year of lung cancer screening patients. You know, I know the numbers are still dismal, but for LifePoint, we set a goal this year, and it may have been derailed a little bit by COVID, and it probably has, but of 10% in all of our facilities across the country. So we even have some facilities in Nevada, so that's an uphill battle, right? You know, but you know, so we you know, but I think for 88 hospitals, if we can get 10%, you know, and I guess COVID may have ruined that a little bit, but we'll see. I mean, things are kind of back online a little bit for us as far as lung cancer screening and how we're getting those patients in and safely doing that. So we're seeing our numbers start to tick back up, actually, so which is good.
That was good.
I do not see any further questions. Any last thoughts from either of you all?
Well, I'll defer my time to Dr. BHADRA and so he can use the time to share wisdom with everyone. So Dr. BHADRA, please, closing remarks. I guess he hung up.
So. No, I didn't hang up. I'm having some sort of internet issue, so I'm going in and out.
Oh.
Well, I did send a little note on the chat feature, but the recording will be ready in about a week, so you will be getting an email with the link. And I thank you both so much for taking your time and sharing of your talent and your education and experience.
Thank you, everybody.
And reach out anytime. We're here to help serve you. And thank you for all you're doing.
Thank you, everyone, and do stay safe. Thank you.
Thank you.
Bye-bye.
Stay safe. Thanks.